Good morning, everyone. I'm student Do Ting Lian, studying Bachelor of Nursing Science with honors. As a renal nurse working in outpatient dialysis center, I would like to share my experience navigating crisis in outpatient dialysis. A reflective journal wrote by my own. In the high acuity environment of an outpatient dialysis center, we function as the primary clinical guidance for patients undergoing complex extracorporeal therapy. Dialysis nursing is a unique specialty that demands not just technical proficiency but hyper vigilance regarding hemodynamic shifts that can occur within seconds. As a staff nurse with 6 years of experience in this unit, I've learned that care is often a balance between machine precision and human unpredictability. Today, I will reflect on a challenging clinical shift where I had to manage severe simultaneous patient needs and unexpected emergencies. To guide this analysis, I'm using Gibbs Reflective Cycle 1988. I will also examine my actions through the lens of Banner novice to expert theory. The Eisenhower matrix and the evidence art 1950 to identify how I can enhance my effectiveness as a clinical leader. Okay, let me describe that situation. The incident occurred during the turnover period, the most chaotic hour in any dialysis unit. My assignment consisted of 4 chronic patients, and we were operating with a lens skill mix, which left very little room for error. At Station 4, Mr. K, a 68 years old with comorbid heart failure, was in his 3rd hour of treatment. Suddenly, the machine arterial pressure alarm triggered. I noticed Mr. K was yawning and complaining of severe abdominal cramps, classic indicators of intradialytic hypotension, or we call it IDH. Before I could stop the ultrafiltration, he lost consciousness and his blood pressure crashed to a critical 78/42 mmHg. Just as I initiated the emergency protocol, a cry of distress came from the next station. My junior colleague had accidentally infiltrated a patient fistula, causing a massive and rapidly expanding hematoma. I was trapped. I had a patient in a medical emergency, a colleague in a technical crisis, and 3 other patients waiting to be disconnected so the afternoon shift could start on time. So now I'll share about my feelings. With 6 years of experience, my response was a mix of clinical alarm and a deeply ingrained sense of duty. I felt a sharp surge of cognitive overload, but unlike my earlier years, this was tempered by what I call clinical muscle memory. I felt physically anchored to Mr. K, yet I felt a profound sense of professional guide because I could not immediately assist my junior nurse. In our open bay unit, 12 other patients were watching on me. I recognized that as a senior nurse, my facial expressions are a management tool. They serve as a barometer for the unit's safety. I force myself to maintain a calm exterior to prevent a ripple effect of panic. I needed Mr. K to see a credible professional when he regained consciousness so he could trust me in his moment of extreme vulnerability. For evaluating my actions, my clinical interventions was effective. I followed standing orders for IDH perfectly. Triangular positions, posing the UF, and a saline bolus. Mr. K stabilized quickly. I also successfully used horizontal leadership by directing a technician to fetch the emergency trolley so I didn't have to leave the bedside. However, my time management was ineffective in the larger context. I developed tunnel vision on Mr. K and failed to delegate outwards. I didn't tell the shift lead that my other 3 patients were now stalled, which led to a significant bottleneck and a 20 minutes delay for the entire afternoon shift. I also realized I have neglected the junior nurse until the hematoma had already caused significant tissue swelling. So looking at the pathophysiology, KDOQI 2020 guidelines suggest that IDH often result from an aggressive ultrafiltration rate exceeding the patient's plasma refill rate. In Mr. K's case, the removal was too aggressive for his compromised cardiac history. This shift taught me the controlling function of management, monitoring the trend of patient, not just the machine numbers. Regarding staff skills mix, Patricia Banner-Trolley explained that while I'm at the proficient state, my colleague was a novice. I should have recognized that a junior nurse assigned to a difficult fistula was a high-risk situation and offer a pre-cannulation check. Using the Eisenhower matrix, I correctly prioritized Mr. K in quadrant 1, but I failed to use rapid delegation for the simultaneous fistula crisis. I tried to do too much myself. In our Malaysian context, the Evidence Act 1950 met our dialysis floor ship's primary legal records. During the crisis, I performed life-saving work but failed to document it in real time. This creates a risk gap. If a patient has an adverse outcome, the court looks at the timeline. If my documentation is written 2 hours later, it is a probative value in weakness. I learned that as a staff nurse, my clinical excellence must be matched by strict clinical documentation. So in reflecting on this shift, I realized that being an effective staff nurse in a specialized dialysis unit is more than a technical role. It is an exercise in clinical management. After 6 years in this center, I previously focused on only on my assigned patients. However, this perfect storm of a medical emergency and a colleague procedural fail has reshaped my perspective. I now understand that professional accountability extends to the collective safety and operational flow of the entire ward. This experience highlighted that even an experienced nurse can fall victim to task saturation. My goal now lies in transitioning from a competent practitioner to a horizontal leader. While I saved a life at one station, my failure to manage out caused a 20 minutes delay for the next shift. I learned that stepping back to assess the wider ward is not an abandonment of the patient, but a strategy necessity to ensure no one patient or colleague is left vulnerable. Finally, I now view contemporaneous documentation under the Evidence Act 1950 as an intrinsic part of the real work, serving as a protective shield for both the patient and my own professional integrity. To enhance my future effectiveness, my action plan focuses on 4 strategy pillars. First, I will advocate for 10-minute safety hurdles at every shift change by identifying high-risk patients, such as those with high fluid gains. We can move from a reactive emergency mode to a proactive prevention mode. Second, I will formalize P2P mentorship by implementing a second eye protocol as a senior nurse. I will offer to assess difficult vascular access before a junior colleague attempt cannulation, creating a safety net for both the staff and the patient lifeline. Third, I will refine my crisis resource management by using the ASPA framework to manage up more effectively during emergency. I will practice the 10-second rule, briefing, stepping back to scan the ward and communicate my status to the shift lead. I will also advocate for a script during crisis to ensure our documentation remains legally defensible. Finally, I commit to researching non-invasive reactive blood volume monitoring. By becoming a champion for this technology, I can bridge the gap between bedside care and technical advancement, aligning our unit with global KDO QI 2020 standards. Ultimately, this experience has moved me closer to the expert state of practice, where intuition is backed by rigorous management logic. Thank you for your time.